Hello, my name is Mackenzie Wilcoxon, and my topic was over child sexual abuse and development. So, sexual abuse is difficult and traumatic at any age. It affects your perceptions of the environment, others, and yourself. It affects the victim, friends, and family, but what happens when it is a part of your foundation? Child sexual abuse can affect individuals' beliefs, coping mechanisms, and biases from the very beginning. Therefore, the topic of this presentation is child sexual abuse in children after 5 years of age and what this could mean for adolescence and adulthood. So to set the tone of the presentation, I would like to highlight one specific quote from Knoll and colleagues. Their research encompassed this one main idea: no sexual abuse should be considered to be mild. Therefore, we will look at a diverse set of research and stories centered around childhood sexual abuse. So first, I would like to define some terms and concepts that will be included in the presentation. There were several definitions of childhood sexual abuse. However, I believe that Faring and colleagues' definition does a fine job. So they define childhood sexual abuse, or CSA, as involves the unilateral imposition of adult sexual desire on children. And then there's stigmatization, which includes shame and a self-blaming attributional style. And then shame is seeking to hide one's perceived damage from others. And then finally, there is self-blame, which is when an individual feels responsible for the abuse to some degree based on behavior or characteristics. So the next set of definitions are from Merrill and colleagues. So they define traumatic sexualization, which refers to the shaping of a child's sexuality in an interpersonally dysfunctional manner, leading to lasting inappropriate associations with sexual activity and arousal. Next is sexual aversion. It is engaging in little sexual activity and having few, if any, partners. And then finally, there's sexual promiscuity, which is engaging in sex with many partners. So to continue Merrill and colleagues' definitions, we have one more, which is dysfunctional sexual behaviors, which refers to sexual behaviors that are self-defeating or maladaptive, such as having sex with strangers, having secret sex, and using sex to gain affection, to cope with distress, or to feel powerful. Next, we'll go on to Dye and Prout's definitions. The first one is self-efficacy, which involves an individual's sense of agency or the belief that one's ability to perform certain actions, as well as the cognitive representation that those actions can be performed successfully. Next is self-regulation, which is the ability to direct one's actions, thoughts, and feelings in an adaptive manner. And finally, there is emotional regulation, which is the ability to control one's subjective experience of emotion, particularly its intensity and duration, as well as to express that emotion to another person. And so the research by Dye and Prout includes a few more definitions, but I will leave those for our next slides. Now that we have covered some of the basic terms, we will now discuss how CSA affects development. So we will first discuss outcomes in childhood. So to start, there are 3 selves that are more prominent during middle childhood, which is internal self, social self, and socially comparative self. Therefore, when children who have been sexually abused at an older age, which is older than 5 years old, they compare their own attributes and abilities to their peers. When they realize that they do not have the same lifestyle or have experienced more traumatic experiences, they may make assumptions about their own efficacy. So, abuse, whether that be physical, sexual, or psychological, disrupts the self's development, which includes self-agency or self-efficacy. When comparing themselves to their peers, they see themselves as inferior, less favorable, and incompetent. This is where the terms we reviewed come into place. Self-regulation and emotional regulation, which includes seeking social support and using problem-solving strategies, are less likely to be used by children who have experienced CSA. So moreover, there are 2 strategies we will highlight, which is problem-solving strategy and emotion-focused strategy. So for problem-solving strategies, they are solace-seeking and help-seeking, whereas emotion-focused strategies use distraction and avoidance. So the emotion-focused strategy is similar to symptoms of PTSD. Therefore, individuals who believe they have little control will use this strategy. And also the diagnosis of PTSD correlates with lower self-efficacy in social situations, enlistment of family support, and use of emotion regulation strategies. So in a clinical setting, the treatment goals would focus on reducing hyperarousal and utilize problem-solving coping skills instead of emotion-focused coping skills to increase emotional self-efficacy. And then emotional self-efficacy is the belief that one is in control of one's emotional experiences from the perspective of mastery and positive self-regard. All right, so next we will discuss outcomes in adulthood, which is posed by Merrill and colleagues. So child sexual abuse, or CSA, has been associated with numerous negative outcomes, such as anxiety, depression, suicide attempts, low self-esteem, substance abuse, and problems with trust and intimacy. So there are two pathways. There's aversion to sex or sexual promiscuity. Aversion to sex is paired with the avoidant coping strategy, and sexual promiscuity is paired with the self-destructive coping strategy. So the study conducted by Merrill and colleagues found that there is a relationship between self-destructive strategies and dysfunctional sexual behavior, and a relationship between dysfunctional sexual behavior and the number of sexual partners. Therefore, to cope, individuals who have self-destructive tendencies may have more sexual partners to cope when in distress. This could also lead to outcomes such as STDs or re-victimization because of the risky sexual behavior. As for avoidant coping in sex, this does not mean that such individuals who have experienced CSA never have sex. The women in the study that used the avoidant coping strategy had on average 8 sexual partners. Theoretically, the individual will use the avoidance strategy if it alleviates distress in sexual situations. If there is no distress, the avoidance strategy is not needed or used. So for the goals and therapeutic outcomes, the researchers suggested that by decreasing self-destructive coping, this may lower high-risk sexual behavior. By learning adaptive coping strategies, it could help women to find satisfaction outside of sex, or decreasing the risk of re-traumatization. So I would now like to address outcomes in parenting. So based on the research conducted by Bertelsen and colleagues, 31% of adults have experienced early life maltreatment, or ELM. This includes sexual, physical, or emotional abuse during childhood or adolescence. It has been found that ELM increases the risk of internalized disorders being passed down to female victims' children. This could be due to poor parental practices consisting of authoritarian and permissive parenting, or the influence of depressive symptoms. There's also epigenetic factors, which could include passing down altered genes, or there could be difficulties with attachment. So there were 3 important takeaways from the study. The first is that children of mothers with ELM believe they had more anxiety symptoms than those whose mothers didn't have ELM. The second is it could be interpreted that mothers with ELM are more attuned to children's symptoms of anxiety. And then third, it is important to address parents' early life experiences to understand the effect they may have on youth's anxiety symptoms. And we will now turn to developmental theories that we have discussed this semester. So the 2 main theories that I will be discussing is information processing theory and social learning theory. Both theories were utilized during 2 separate studies. The first study used the information processing theory to determine if women who experienced CSA described themselves more negatively than those who did not experience CSA. So women who experienced CSA were more likely to describe themselves negatively and less likely to give positive meaning to sexual behavior words. This relates to information processing because, based on the experience, the researchers sought to understand how the women coded the situation into their mind, interpreted it, stored it, and recalled the information for the study. So the second study focused on social learning theory. The researchers, Dial and Prout, who I highlighted in the outcomes in childhood slide concerning self-efficacy, found some interesting findings. So they found that higher self-efficacy correlates with better emotional health, When leading to adulthood, it is more likely that those who experience CSA had higher counts of self-blame and self-denigration and lower self-efficacy. Overall, this could be due to the lack of development of the child and ability to understand the abusive events. We will now move on to application, which will consist of sexual abuse trends and therapeutic practices. So based on the study by Faring and colleagues, almost all of the perpetrators were known to their victims, with 35% being a parent figure, 26% being a relative, 36% being a familiar person who was not a relative, and then 3% a stranger. So as for the study by Meston and Hyman, approximately 24% of the reported incidents that occurred as a child involved an acquaintance, 72% involved a family member, and 4% involved a stranger. As for adolescent trends, approximately 28% of the reported incidents that occurred as an adolescent involved an acquaintance, 40% involved a family member, and 7% involved a stranger, with also 25% involving a dating partner. In all but 2 cases, the person involved was male. So overall, it is important to note that when working with victims of CSA, there is a high likelihood they know the perpetrator. It is also important to note the outcomes of victims of CSA due to perceptual distortions. These can be expressed through higher sexual activity, prostitution, early pregnancy or teen pregnancy, sexual risk-taking behaviors, early intercourse, sexual avoidance or sexual dysfunction, compulsive sexual behaviors, and they use birth control less often. So just some facts based on the distortion outcomes. Based on the stigma surrounding victims of CSA, individuals might experience a self-fulfilling prophecy, or they may take on the beliefs of the stigma. Early motherhood is not fully understood, but it has been speculated that having a child might be healing for the mother. It is possible that the mother would view the child as redemption or creating a person that is loving and will never leave her. However, this is speculative. And then those who were sexually abused by their biological father had a higher likelihood of sexual aversion and distrust in men due to overgeneralization. So self-blame attributes might take place within the child if the biological father who is abusing the child is not physically violent, even though there is still an obvious power dynamic. So the last point that I would like to make is therapeutic techniques. So possible techniques include number 1 being anatomical dolls. So in the study by Terry and Lamb, they found that doll usage by older children, which is 7 to 12 years old, was more productive in verbal descriptions and enacting their experiences simultaneously, these experiences being child sexual abuse. And the younger children, which is 3 to 4 years old, failed to understand that the doll was a representation of themselves or others. Although there were advantages and disadvantages, using a doll to assist in recalling details for older children may be beneficial. However, I would proceed with caution as not to mix exploratory play, which is fantasy play, with reality. It would depend upon each child whether the technique would be beneficial. Next is human figure drawings. So in the study by Aldridge and colleagues, this technique would be used during an investigation when allegations are first surfacing. However, it could be still used to clarify children's experiences. It is important to note that when giving a prop or using the drawing, adults do not present leading questions. Children may agree to such events or acts that did not actually take place. Free recall and open-ended questions are most helpful when speaking to children. However, it is important to understand that based on development and chronological age, children may need more prompting than others. Next is interventions that focus on youth's cognitive and emotional processing of the abusive experiences. And then there is trauma-focused cognitive behavioral therapy, which is more effective than child-centered therapy because of self-blame attributions, shame, PTSD, and depression. And then there's adaptive skills for processing and coping mechanisms. And then age-appropriate education about sexual thoughts and feelings. And then finally, if the individual is partaking in risky behavior, it would be important to include early interventions that target stigmatization to lower the risk of HIV and STDs or STIs. So in conclusion, I would like to reiterate that no sexual abuse experience should be considered mild. Empathy, understanding, and knowledge are all required to provide the best services for those who have experienced child sexual abuse. It is important to become familiar with common terms and trends along with possible outcomes, beliefs, and distorted expressions. Every person deserves the best care, so it is our responsibility to ensure competence. Here's some resources that I attached to further education about childhood sexual abuse, and you're more than welcome to pause the video at this time. And then here are my references.